Okay, hi everybody. Adam Yanke from Rush University. Thanks for the intro. And we've got Aaron Krych from Mayo, who's going to be demonstrating MACI. I believe he's going to be doing it in a femoral condyle. So again, we're going back to a cell-based technology, and we can talk about those differences for the indication. Some of us using it more in the patellofemoral joint versus the condyle. Aaron, how you doing over there?
Good. Can you hear me okay, Adam?
Yeah, I can hear you great.
Well, fantastic. So we're going to be demonstrating MACI on this knee. And I guess the first part of this is letting everyone know what MACI is. So I think it's an exciting time in cartilage repair surgery, and it's a fantastic course. And it's interesting when you look at the history of ACI. We just celebrated the 30th anniversary of ACI this summer in Gothenburg, Sweden. In the U.S., ACI started in 1997. And that was largely, the FDA approved that based on Lars Peterson and Mats Brittberg work in Gothenburg, Sweden. And now MACI became FDA approved just early in January of 2017. And this was largely approved based on the European data with the SUMMIT trial. And the SUMMIT trial was a multi-center randomized prospective trial of MACI to microfracture. There were about 72 patients in each group, minimum 2-year follow-up. And what they found was that the safety of MACI was very similar to microfracture, but the clinical results were superior, both for KOOS ADL score, for KOOS pain, as well as for KOOS function. So again, it's a very exciting time. So what is MACI? I don't know if we can zoom in on the external camera here. But MACI is expanded autologous cartilage cells that are grown on this membrane, so matrix-associated ACI. So as we all know, the first generation ACI was very large open invasive surgery with periosteal suturing as the cover. Then second generation technology came from ACI when we started using a porcine collagen 1,3 membrane, and that's exactly what this membrane is. And now we're at third generation, which is MACI. So Carticel is no longer produced, now it's MACI. So you perform the first stage of the operation, doing the scope and the harvest. You send those cells out to the lab in Boston, and then you have this MACI membrane that's ready to go. And the membrane dimensions are 5 centimeters by 3 centimeters, so this will treat up to 14 centimeters square defect, so quite a large defect. If you look actually at the membrane, you can appreciate a notch in this lower left corner. And with this notch oriented in the lower left corner, I don't know if you can see that, but it's the rough side of the membrane that's up. That's the part where the cells are actually adhered to. And the cells, there's 500,000 cells per centimeter squared of the patch. And then on the top side, this is the shiny side, that provides a smooth articulating surface. So your cell side will go down to the bone to integrate both horizontally and vertically, and then the shiny side goes up towards the joint surface.
Aaron, can you talk a little bit about when you're doing the biopsy, where you take it from and the depth and the amount?
Yeah, so it's recommended that either take the biopsy from the notch or from the most lateral aspect of the lateral trochlea. I typically use the standard method, which is the gouge. And you want about at least 200 milligrams. So I shoot for about 2 to 3 Tic Tacs. It's very important that you harvest all layers of the cartilage. So you really want to get down to the bone level to make sure that we have cells from all layers of the cartilage. One of the other things with growing cells on a membrane, so if you, one of the problems with expanding chondrocytes in the lab is that when you get to passage 2 on a petri dish, the cells really lose their phenotype and they undergo dedifferentiation and become kind of almost fibrous-like cells, but grown on the membrane, they maintain their phenotype. So I think that's a big advantage with the matrix-associated ACI.
Yeah, that's great. And then can you talk a little bit more about the timing from the biopsy? I know you said the fastest it can kind of happen, but What if the patient's not ready, or how do you make that decision of when you're going to move forward with implantation?
Yeah, so logistically, we'll perform the arthroscopy, and then you'll get an initial notice from Vericel basically on how your harvest was. So they'll actually give you a weight of your harvest, which is great. If you have a low weight, less than 200 milligrams, they will let you know, so they'll give you that feedback. Then once the cells are basically undergo their first initial expansion, then they basically contact you, and that's the time to discuss it with the patient. Are we ready to go ahead with stage 2 or not? And if they're ready to go ahead with stage 2, if they have good range of motion and such, then we start to plan a date for surgery. I think one of the great things about this type of cartilage repair technique is if you have a very complex case, with a meniscus transplant, an osteotomy, sometimes a revision ACL, this is nice because you can plan that date for surgery and take the time that you need on your schedule. Sometimes with waiting for a graft, the timing can be a little bit tricky. The more complex the surgeries are.
Great, thanks.
Can you just talk for a second about the authorization challenge? Oftentimes when you're doing your first stage of your harvest, you've seen the defect, you've decided on your strategy, and therefore you're harvesting your Tic Tacs and sending them away, but you don't necessarily have your authorizations yet. So can you talk about the company's philosophy about accepting and beginning culture prior to authorization and prior to the finalization of step 2?
Yes, I guess in general, what I would recommend is that you're just not taking many biopsies as just-in-case treatments. I think if you're moving forward with the biopsy, you should really have this as a potential treatment in mind. So that starts when I meet the patient in clinic. Unfortunately, if I see a candidate for this MACI technology, the first thing I'm doing is checking their insurance information. Often the major insurance carriers will have in their policy specific guidelines, and typically we aren't able to seek insurance approval until we do the biopsy and the cells are in lab. But I think that's a very important point, is that you start thinking about that and documenting exactly what are the indications for the MACI procedure for that patient. And I think looking at some of those insurance policies and the patients in your region, I think can be very helpful. And then again, once the cells are there, then we begin seeking the pre-approval process for the cells and the implant.
Yeah, definitely. I think to get to your point, they would basically don't start growing them, or you don't start planning that until you've gotten the approval, because at that time you're pretty much committed, so to speak. I think also you talked about a little bit about incidental lesions. That's really not why you want to do these biopsies. It should be because you're ready to treat it and you're telling the patient ahead of time, we're starting a 2-stage process and this is the first stage. If you happen to feel better from the debridement, then that's fine and we stop. But if you don't, then you're ready to move forward. And I say that if you have, and Aaron, add what you think, but if you had a 60% reimplantation rate from your biopsies, I'd say that's pretty good.
Yeah, I think overall that's very good. And we should mention while we're talking about indications, so the original ACI technology, again, was FDA approved based on Lars Peterson's data, and patella became off-label, as did tibial lesions. But now with MACI, basically it's FDA approved for the knee. So in theory, you could treat any lesion in the knee under FDA approval. So with ACI, I used to have to tell patients, for patellar lesion, this is off-label. Using the membrane, the porcine cover at that time was off-label. Now everything's on-label, FDA approved for any lesion in the knee.
Yeah, and it depends on the insurance company, but it can still take some work, and so you may get an initial primary review that's not an orthopedic surgeon. They'll basically just read the insurance's policy and say, we don't take it, and then you're denied. You have to do an appeal, get a higher level appeal that's orthopedic specific, and then some of them will actually take into account the literature that exists for the multi-center studies for the patella. And so it's probably getting a little bit easier now than it used to, and certainly the writing in the insurance policies is better than it's ever been.
Yeah, I think the data has become more and more robust over time. Tom Minus just published minimum 20-year follow-up on his ACI patients in this last month's AJSM. So I think we do have good data. Again, that's based on ACI and not necessarily MACI, but there's a lot of good data on MACI out of Europe as well. So it has been, you have a little bit more, ammunition for the insurance companies to write, a letter of appeal or to do a peer-to-peer review process.
Do you feel like, before we get to your implant, any of your indications have changed using MACI compared to ACI?
That's a good question. I don't think so. I mean, I do think it's a good, one of the advantages of it's versatile. You can use it for condylar lesions. You can use it for multifocal unipolar lesions. I still think it's one of the best treatments in the patellofemoral joint. So I don't think the indications have necessarily changed in my practice, but it is a very versatile technology.
Yeah, and I think that some people are still concerned about uncontained defects, and it just depends on where they're located and really what the mode of uncontainment is, if it's something you can kind of improve at the time of implantation. But you really just want to make sure it's not something that's going to dislodge your graft, most importantly.
Yeah. So we should probably get started here at the knee. So one of the points I wanted to make is typically when you think about ACI, you thought about maximally invasive surgery, because you had to make such a large incision, you had to harvest the periosteum. But now with gluing these implants in, there's no sutures anymore. I mean, you can really get by with just a mini arthrotomy for these procedures, which I think is really a big advantage. So we'll take a look here. This is a medial femoral condyle in a left knee, and I was going to look at this cartilage quality. You can see this cadaver has some arthritis without a lot of cartilage left on that medial femoral condyle, so I'm not sure if I'll be able to get good vertical borders. So what I might do is I might just go over to the lateral side just to make sure that I'm adequately demonstrating the technique. So I'm just going to enlarge this incision, but again, normally you could do this through a very small incision because of the gluing technique. So this lateral femoral condyle, I think, will be in better shape here. So to prepare the defect, I'll use the same Askelapp instruments. I first learned about these instruments when I was traveling in Europe in 2013, and I had the privilege of watching Daniel Saris operate at the University of Utrecht, and it just seemed to really simplify the procedure. Again, it's what's also nice for research purposes and your dictation purposes, the exact area calculated on here. So we'll prepare the defect in a very similar manner.
Yeah, and it's really crucial that these are sharp. I mean, no matter what you're using, dull instruments will make everything much more difficult.
So here we'll have a contained lesion.
And so if you don't have these things, then there's other methods you can use too, like the 15-blade knife, so you can kind of go around. But either way, you want to develop sharp edges first, and usually it's easier to do without the curette, some kind of a sharp device to really make a perimeter.
Do you actually have those instruments available with Mayo?
What was that, Jack? I didn't hear your question.
Do you have these available clinically in your practice, the Askelapp instruments?
Yes, so I purchased the set, and I have them available, yes.
So what level, I know you're going to get to it, but what level are you trying to take this down to? What are you looking for doing too much or too little at this stage?
Yeah, so I want to get down to the calcified cartilage layer just with the kind of the gross preparation. Then when we fine tune it, I want to get just through the calcified cartilage layer, but I don't want to get into any bleeding bone. We've worked hard to grow nothing but these cartilage cells in the membrane. We don't want really any fibrous ingrowth, between our implant.
So what? I know that we're in a cadaver here, but let's say that you got into some bleeding bone. What's your method there? Do you let the tourniquet down, fibrin? Or what do you do?
I mean, your knee's in flexion, so you get kind of a tourniquet effect with the vessels anyway. One other tip that's really helped me is we've started using tranexamic acid on all the cartilage patients. It's been shown, it has tremendous safety data from our total joint colleagues. And then I started using it on osteotomies and saw a huge difference in less bleeding. And since that, I've been using it in the cartilage patients, and I've noticed perhaps that their subchondral bone bleeds a little bit less. So I think that's a big advantage. If you still have bleeding, I sometimes will use Pinpoint Cautery. I find that helps if you have just little punctate bleeding. If you have larger areas of bleeding, then either epinephrine soaked sponges are just fine, or you can also use Fibrin Glue at its base. But you really want to make sure that you've got the bleeding to a minimum.
Yeah, and the removal of the calcified cartilage layer is an important point and a difficult one because it's hard to know when you've been successful and how much to take down. The bigger your curette is, the more your force is going to be distributed, so it's generally less pressure. And so that's good to remove cartilage. Then if you use a smaller curette with the same amount of force, you'll get a little bit more pressure focused. And then you'll usually see that you can get deeper much faster. So you got to be careful you're not going too deep. But if you're having trouble identifying the layers, when you still have that kind of milky white glassy surface, that's probably the calcified cartilage layer still at that point.
Yeah, and I think I don't know if you can appreciate the sound here, but you can hear when you still have that little grizzle. That's your calcified cartilage layer, and then when you lose that sound, then it's gone. So that's something I teach the residents and fellows. But you can still hear it there. I don't know if you can appreciate that in the room.
Yeah, it sounds nice.
Your favorite sound?
I love it.
Aaron, this is Jack. I also use tranexamic acid, but there are multiple different ways that the joint surgeons have described to use it. What's your technique?
I'm sorry, I didn't hear you, Jack.
He was wondering how you deliver the tranexamic acid.
So IV, it can also come topically that you can apply it, but we apply or run 1 gram IV before incision. And if you're going to use a tourniquet, then you can administer a 2nd gram IV when the tourniquet comes down. But if you use it for your osteotomy patients, it's just amazing the difference. They don't get that soft tissue bruising that they would typically get. So I think it's definitely been an advantage in my practice.
You give that at the same time you give your prophylactic antibiotics, or
Yep.
is it?
Yep. We run it through the checklist with anesthesia.
And just not to harp on it too much, but to give you an idea, the calcified cartilage layer is like less than 0.1 millimeters thick. And some of the people that pioneered how we know to remove it, like Frisbee and McElraith, did it on over 50 to 60 sheep and had to do histology on all those to really get good at it, to remove just that portion. So it's tricky, but it's an important part.
Yeah. How's that looking, Adam? Is that about what you would do?
It's awesome. It's better than I can do, which I expected.
So then we basically have our preparation there. So typically in the operating room, if we had bleeding, this is the point where I would have my PA apply Fibrin Glue. He has a very large thumb, thankfully. And then he would hold that for 3 to 4 minutes while I'm preparing the graft.
What I know that this can apply to multiple cell-based technologies, but what about where you stop debridement, and how far do you go into cartilage that is soft but visibly looks okay?
Yeah, so that's a great question, and I think it's a huge advantage for ACI or MACI because the theory is, if you have a sized implant, so let's say you have a 2 centimeter disc or something like that, or even when we're doing osteochondral autograft transfer, I think the tendency is to make the lesion smaller than it should be because you're trying to make that area smaller for your implant to fit it. Here, what you want to do with ACI, which is classically taught, and MACI, is you want to radically debride all diseased cartilage with full thickness fissures, etc. If you think about the cartilage integration, you want it to integrate to nice, healthy surrounding articular cartilage. I'd be worried about putting this implant up against cartilage that isn't, that's still diseased. Lars Peterson did some nice work showing that, if you have the cartilage lesion, you have this kind of penumbra zone where you still have some apoptotic cartilage cells, and it's about a 2 millimeter rim. So in general, I try to clean at least a millimeter beyond what I see as diseased cartilage.
Yeah, that's great.
So there's two different ways to basically size your implant. So one is the same as Dr. Meininger showed on the first demonstration, which is you can actually do the cookie cutter method, which I will typically do. If you don't have the instruments, the other option is to use a foil template. For some reason, the fiber wire foil works best, so that's what I would typically recommend using. You want to make sure that your foil template is very precise. Because you don't want your graft, hanging over the edge. So what I'll typically do is I'll just start by kind of pressing, and this foil is nice because it has memory, so it really indents well. I don't know if you can appreciate that. But now you have your shape. So I don't know if you can see that.
Yeah, we saw it pretty good in the joint itself. Yeah, we can see it there. Yeah, that looks nice.
So then I if you're going to use the foil template method, I take some time here and I make sure this is perfect.
How would you say your sizing is relative to the defect? You try to oversize it, undersize it as far as the foil goes?
Well, it's I try to bring it flush against the articular cartilage walls. So you don't want it overhanging. The implant itself, you can either have side to side with the cartilage. It's okay to come up a little bit on the wall of the articular cartilage. That can aid your horizontal integration, but you certainly don't want it overhanging because you will, you worry about graft delamination.
Yeah, and I think that, like you said, you don't want it to be too big for sure. But if you have a tendency to cut on the outside of your foil when you put your actual graft on, you may want to keep your foil a little bit smaller, but that's just a personal thing based on how you cut.
Yeah, and I would, this is the part of the operation I slow down, and if you're going to use this foil, it's got to be perfect, just absolutely perfect. So to me, that looks very, very acceptable there. I don't know if you can appreciate that. I don't know if you can have an exterior camera here.
And so that would be obviously non-sterile. This is just for the demo, but that would be handed to him, and then he would have to lift it out, essentially. Yeah.
So what I would do is I would have two non-tooth forceps typically in my cartilage specials pan, and then again with this, the recommendation is when you have this again notch in the lower left corner, that the rough side up is the cellular side. I would typically have my circulating nurse hold this, and then what we'll do is we'll use this white paper here as a backstop, and that's just from the fiber wire. So we'll actually lay this right on there, and this will facilitate some of the cutting that you can do. Can you see that? Okay.
Yeah, I think it's showing up pretty well.
So now, if you're gonna keep this side up, essentially upside down, then what I'll do is I'll take my template and go upside down. Now this is an oval, so it's symmetric, but if you have a regular geometric shape, then you can just essentially do it like this, and then at the end you'll flip just so you keep your orientation. And sometimes I'll put just a dot in the top of my foil so I know that that's north. Again, I try to avoid using marking pen, for this.
Can you maybe just turn the lights down a little bit? It's washed out a little bit.
We able to?
Yeah, that's great.
So typically, if you're going to use your foil method, this is what I would do, and it's helpful to have that white backing so your scissors can actually go through it.
Yeah, and so that's the same backing as your fiber wire, right?
This is the same backing as the fiber wire. And what I typically do, I like to just, if you're treating more than one lesion, I'll just cut this excess, and you can put that back in the fluid, make sure it stays moist, for the case. And then you could just cut it out. And again, that's why it's critical to get your foil template perfect.
How would you describe your digital pressure there?
Light but firm.
Yeah. I like it. Yeah, I mean, just as you said, you don't want to manhandle the graft.
Yeah, and that's why, you know, the cells are up at me with the way we've done this.
And so keeping that orientation correct, like you mentioned, having the notch in the bottom left, knowing that you're usually going to pick it up and kind of invert it as you bring it up into your defect. So if it's asymmetric, that's a really crucial point that's easy to forget when you're in the OR and just trying to move forward.
Yeah, and then sometimes I'll flip it over. Sometimes you can see a little bit better. You know, if your implant's hanging over a little bit, I don't know if you can appreciate that.
Yeah, we can see that.
But I'll just fine tune it. So, to me that looks pretty good.
Yeah, that's great.
Might be, I'm trying to see my foil outline here. It looks a little wide over here.
Again, really sharp instruments is helpful because it can be a little trickier than you think. It wants to slide around a little bit.
Yeah, I keep a Cartilage Specials pan, you know, with sharp Jones scissors. So to me that looks pretty good. So that one's essentially ready to go. Now, if you wanted to do it the easy way, you would just use the cookie cutter. So we've had arts and crafts, now we have baking class. And yep, we can pound that down.
You ever have a gingerbread man shaped defect?
What's that, Adam?
No, nothing. It wasn't important.
So I mean, how easy is that? So
I'm buying a set of those instruments.
Yeah. So if you like to be meticulous and take your time, then method number one. But otherwise, I mean, this thing is super quick, which has really been a change from the original ACI. So I have something in my gloves here, but
yeah, that's awesome. That's a great.
So that's super quick.
Great way to do it.
So then this is our Fibrin Glue. So this will come frozen, so you have to make sure that your nurses are helping you out by making sure that that's thawed and ready to go, because sometimes you're so quick now that you'll beat them. This isn't even thawed before it's ready. So we'll put the tip on, and then we'll just come back to the knee here and get set.
So the biggest difference between manufacturers for that, correct me if I'm wrong, is that one is already mixed, or does it mix also as you inject?
This is, yeah, it's a dual chamber here. I don't know if you can see, but it mixes as you push it forward.
Right, and so that you can get some that, but that, I guess I should have been more clear, the actual catheter is not split. Is
Yes.
that correct?
That's correct, yeah.
So there are some that are split at the catheter so that it doesn't mix until it actually gets out of the entire device. So just know that you have to clear some, and usually there's a spurge there, or purge rather.
So this is where we do our final check for our bleeding, just to make sure it's good. If you need another application of Fibrin Glue or something like that, you can certainly do that. But it should be ready. So then what you want to do is you want to apply just a thin layer of Fibrin Glue. I often get this Fibrin Glue kind of running. You want it almost like a mucus consistency. You just want to make sure you get a thin layer all the way around the bottom of the defect. And then that looks pretty good. And then now we have our implant. And remember, the rough side was up, so what we're going to do is we're going to flip it. If I can just get this out here. I find that a joker works well in surgery. Then you just want to make sure you flip it. So this is fitting really nicely. You see it just a little bit coming up the wall, which is fine.
Which one did you use? Your scissor one or the implant one?
You know, I don't even know which one I used. Yeah, I used the cookie cutter.
Okay.
So then you have to hold pressure for 3 minutes. What I do is I just put a little saline on the back of my thumb. So you're supposed to put a 3-minute timer, and this is definitely the longest 3 minutes of your life, no doubt.
But shorter than the 20 minutes of suturing.
Yeah, 20 minutes plus. But again, you can see, you know, we're over on the lateral side here, but you could certainly use just a mini arthrotomy. You know, it adheres very nicely.
But that point of having saline or even the media on your thumb is important, because if it has desiccated and your thumb's dry, you could end up with that scenario.
Yeah, definitely would not want that to happen. I'll kind of wait the full 3 minutes. Any other questions at all? But the technique, as you can see, I mean, it's become so simple. You know, I definitely think it's more reproducible than it used to be with, you know, meticulous suturing technique. You know, oftentimes checking, is it a watertight seal? The nice thing here is you have guaranteed even distribution of cells within the defect. You know, when you're injecting it, you know, you always saw the fluid and you try to create a chamber and hopefully you would get even distribution, but I always wondered about that. Here you're guaranteed, you know, again, there's 500,000 cells per square centimeter on this membrane, so I think it's a large advantage.
Yeah, the other thing that's a little different about some of the technologies as far as the cell-based matrix associated technologies is the thickness of the implant. And, you know, sometimes the thinner implant's nice because you know it's not going to be proud compared to the surrounding cartilage. Some of the implants are a little bit thicker, and I've had some concern that they're too thick for the surrounding cartilage, and they really sit proud, and there's not really any way to adjust that. So this is probably the thinnest one that's there.
Yeah, and if you could, I don't know if you're able to see this with the camera, but it's 0.43 millimeters thick. So it's very thin. And I'll show you once we get done. I mean, this has given me a lot of confidence with rehabilitation. You know, with the old ACI technique, we were very conservative, 6 weeks of toe touch weight bearing. We've definitely accelerated. Now the first 4 weeks are partial weight bearing, and then I let them go to weight bearing as tolerated in week 5 and week 6. I'll range the knee here for you in a minute once the glue is ready to go, but it gives you a lot of confidence that you could maybe even go quicker, especially with these, you know, well-contained lesions on the implant at its base.
Is that protocol you're talking about for femoral condyle or patellofemoral?
For femoral condyle, for patellofemoral, I actually let them weight bear immediately, weight bearing as tolerated, and locked in full extension with a brace, of course. So they don't get the shear across the implant, but you really have minimal loading with full extension for a patellar or a trochlear lesion.
Yeah, so I do the same. I also maybe am a little bit aggressive with range of motion in those patients too. Do you limit flexion at all for a period of time in patellofemorals? I tend not to.
I tend not to, just because it depends what else I'm doing. So practically speaking, the majority of the patellofemorals I do, they're getting an osteotomy, they're getting an MPFL. There's so much reason for them to get stiff that often I don't think they get 90 degrees of motion by 4 or 5 weeks anyway. So I don't even like to put that restriction in their head.
Yeah, exactly.
Because most of the time they won't get to 90 degrees, you know, until later anyway. So.
Yep.
So I guess we can see how we did here. So critically, I think this looks good. It's a little bit up on the wall of the cartilage, but not overlapping. I think you can see just a tiny little pink sliver here. So what we would do is we would add a thin layer, again, of the fibrin glue, just around the edges. You still want diffusion of those cells to occur over the top of the implant. That's important for their health. We just add a little bit here to the edge.
Yeah, and just because sometimes it's hard to visualize the three-dimensional aspects on the video, just like you said, you don't want it coming over the edge. So you want to make sure that it's really tucked in there. You don't want the implant to kind of wrinkle up or have a curtain effect either. So it's definitely a good balance, and that's why he spends so much time with the foil portion of it.
I don't know if you can switch to the arthroscope. We'll use Bert Mandelbaum's trick here. You can see that that's recessed below the level of the cartilage.
Yeah, that's a nice view.
So that gives me just absolute confidence with rehabilitation. Again, this will horizontally integrate to the articular cartilage, and then it will vertically mature over time. So, but to me, that gives me just a lot of confidence for the range of motion, etc.
Yeah, which we're going to test.
Yep. We'll just wait those 3 minutes.
Yeah.
So I think the glue is pretty much dry. So what we can do is, I just want to show you, I'm happy to take this knee through immediate range of motion. You can do this as much as you want. But you can see that implant, is just rock solid.
Yeah, and you really, you can tell he was being aggressive. You really want to know now. You don't want to find out later. So this is the time to do it. Can you talk about, just because we do have a little bit more time unless we want to go to questions, but...
see, the technique's too quick now.
I know, right? Well, there's always stuff to talk about. But any difference in indications for you for patellofemoral joint versus femoral condyle? Are you putting this on the tibia ever?
I haven't done any tibial lesions yet, but certainly theoretically with gluing the membrane you could. It is an on-label use. There's very few options for tibial lesions, but again it's versatile. So you really could use it for any articular cartilage lesion in the knee. People often ask about bone loss. If you look at the European data and Tom Minus's data, you can use it for up to 4, 5, 6 millimeters of bone loss without having to do bone grafting. If you have more than that, then you can consider the sandwich technique. So that's where you use autologous bone graft. You do impaction bone grafting up to the level of the subchondral bone, and then you would put your ACI cells. Lars Peterson just looked up his bone grafting sandwich technique for OCD lesions and had excellent results in almost 90 patients. So again, really is versatile. And you can see with the gluing, you asked about containment of defects earlier. I've had a few patients, with that classic, in patellar dislocation, they get that classic inframedial lesion, which is uncontained. Those are very difficult to treat, but typically they have such nice, stable borders above that you can glue in the implant uncontained if you wish. I've done a few of those patients, which I think have turned out fairly well. If you want to add, little mini anchors on the edges, you can. I don't think it's necessary. I think, the gluing to me gives me a lot of confidence.
Okay, thanks, Aaron.
Okay, thank you.
Indication for use. MACI, autologous cultured chondrocytes on porcine collagen membrane, is an autologous cellularized scaffold product that is indicated for the repair of single or multiple symptomatic full-thickness cartilage defects of the adult knee with or without bone involvement. MACI is intended for autologous use and must only be administered to the patient for whom it was manufactured. The implantation of MACI is to be performed via an arthrotomy to the knee joint under sterile conditions. The amount of MACI administered is dependent upon the size, surface in centimeters squared, of the cartilage defect. The implantation membrane is trimmed by the treating surgeon to the size and shape of the defect to ensure the damaged area is completely covered and implanted cell side down. Limitations of use. Effectiveness of MACI in joints other than the knee has not been established. Safety and effectiveness of MACI in patients over the age of 55 years have not been established. Important safety information. MACI is contraindicated in patients with a known history of hypersensitivity to gentamicin, other aminoglycosides, or products of porcine or bovine origin. MACI is also contraindicated for patients with severe osteoarthritis of the knee, inflammatory arthritis, inflammatory joint disease, or uncorrected congenital blood coagulation disorders. MACI is also not indicated for use in patients who have undergone prior knee surgery in the past 6 months. excluding surgery to procure a biopsy or a concomitant procedure to prepare the knee for a MACI implant. MACI is contraindicated in patients who are unable to follow a physician-prescribed post-surgical rehabilitation program. The safety of MACI in patients with malignancy in the area of cartilage biopsy or implant is unknown. Expansion of present malignant or dysplastic cells during the culturing process or implantation is possible. Patients undergoing procedures associated with MACI are not routinely tested for transmissible infectious diseases. A cartilage biopsy and MACI implant may carry the risk of transmitting infectious diseases to healthcare providers handling the tissue. Universal precautions should be employed when handling the biopsy samples and the MACI product. Final sterility test results are not available at the time of shipping. In the case of positive sterility results, healthcare provider or providers will be contacted. To create a favourable environment for healing, concomitant pathologies that include meniscal pathology, cruciate ligament instability, and joint misalignment must be addressed prior to or concurrent with the implantation of MACI. Local treatment guidelines regarding the use of thromboprophylaxis and antibiotic prophylaxis around orthopedic surgery should be followed. Use in patients with local inflammations or active infections in the bone, joint, and surrounding soft tissue should be temporarily deferred until documented recovery. The MACI implant is not recommended during pregnancy. For implantations post-pregnancy, the safety of breastfeeding to infant has not been determined. Use of MACI in pediatric patients younger than 18 years of age or patients over 65 years of age has not been established. The most frequently occurring adverse reactions reported for MACI greater than 5% were arthralgia, tendinitis, back pain, joint swelling, and joint effusion. Serious adverse reactions reported for MACI were arthralgia, cartilage injury, meniscus injury, treatment failure, and osteoarthritis. For more information or to view full prescribing information, please go to maci.com.